most of the places we are able to get it. So we are also surprised.
Viral panels.
Your respiratory viral panels are available. You do that, and now we have been able to diagnose all influenza, respiratory sensitive virus so commonly, combination of adeno and enteroviruses, COVID we also. So all these viruses are there. Only the issue is that we are not able to diagnose them before these bioviruses.
So as you rightly said, COVID has done one good thing. Many hospitals now have these viral panels which they never had before, and then we are diagnosing these much more hours. Okay. So we did have a few more questions on antibiotic stewardship, but we're going to just, because in the interest of time, not discuss those. We have covered a fairly wide range of topics, and I would really like to thank my panelists for having put in so much effort in having going through the literature and preparing the answers to these questions and making it and giving take-home messages that you can all go back home with. Thank you all very much, and thank you to the organizers once again for giving us the time to discuss this important topic.
We talk about CRP light and left, and we didn't emphasize blood culture here. Especially a preterm babies, I would like to spare that 0.5 mm blood culture, not to sacrifice it for CRP. Number one. And our panelists, do you have any idea that how the gestational age, postnatal age, and the mode of delivery is going to affect the CRP, because we are going to take one single cutoff for all.
You're absolutely right. There are a whole lot of parameters that affect CRP. In fact, the process of birth itself causes a surge in CRP. So there's a physiological surge of CRP in the first few hours of days of life. Term infants tend to have higher CRP values than preterm infants. And in fact, we had done a study in PGI, published in Journal of Tropical Pediatrics, where we try to look at the normative values of term and preterm infants over several weeks of life, absolutely healthy term and preterm infants, who were incidentally having an investigation for something else, say jaundice and so on. And we found that a substantial number of term infants in the first 96 hours had CRP values above 10 milligrams per liter, which is the traditional cutoff. And for sepsis, and absolutely fine. In fact, one of them had something like, I remember correct, some 30 or 40 milligrams per liter. Perfectly normal infant, nothing happened to that infant 1 week or so. So one has to be very careful that not to take all parameters into account before interpreting these single cutoff values. Thank you for highlighting that, sir.
So, Dr. Saurabh, with your permission, only one comment about antibiotic stewardship.
Okay, sorry.
Just one comment. And whenever you make a round, make it sure that you stop antibiotic at least for one newborn on your round. I've been doing it for many years now, and you will always find that newborn where antibiotics are going unnecessarily. So, इससे मैं अपनी round से बोलता हूँ, antibiotic बंद करना धर्म का काम है. Thank you so much.
Thank you very much. Thank you.
Thank you, sir. Your comprehensive exploration of the topic shed light on critical aspects of pediatric medicine and provided us with the evidence-based strategies to enhance our practices. Moving on to the next panel discussion on neonatal protection, brain, lung, gut and eye, we welcome Dr. Gurdev Chaudhary, Dr. Javjeet Dalal, Professor and Head, B.D. Sharma, Postgraduate Institute of Medical Sciences, Rohtak, Dr. Tanveer Bashir, Consultant Neonatologist at Noora Hospital, Jammu and Kashmir, Dr. Tufaila Shafi, Assistant Professor, Pediatric Ophthalmology, Government Medical College, Srinagar. Ladies and gentlemen, our next speaker is an eminent figure in the field of pediatrics who has dedicated their career to neonatology, Dr. Ruchi Nanavati. I request our chairpersons to kindly introduce the speaker.
Good afternoon. Good afternoon. At the outset, I would like to thank the organizing committee of North Zone NeoCon-2023 and Dr. Shaukat and Dr. Ravi in particular for inviting me today and to conduct this panel discussion. Now, as we know that the scenario of neonatal care has totally changed in India over the last 3 to 4 decades. And some of us present here have actually witnessed that, how the neonatal care had changed. And with that, the focus had changed from survival to intact survival. And to achieve this target, to have intact survival, to have intact nation, what we require to protect the organs, and that's the the topic for this panel discussion today. Now, if we have to have intact survival, we require to protect organs right from skin up to the brain, and we are trying to discuss about 4 organs here, and that is lung, gut, brain, and aorta. And to discuss this extensive topic, we have just 40 minutes. So I think it's going to be more like a rapid fire for all of you. So try to answer very clearly and precisely this in a short time. And there is an additional request to sort of finish it 5 minutes early. So so let me start. So I start with first, right from the delivery room, we are talking about lung protection from first breath. So let me start with this, and my first question, of course, goes to lung. Gurudev is going to discuss. And the first question is this: why is the lung protection so important? Do we have any Indian data?
Yeah, lung protection is very important because in our zeal to save these preemies, extreme preemies, sometimes we sacrifice their lungs. So, and very few therapeutic options are there. Once CID is fully developed, prevention of injury is the crux of the matter. Survivors with BPD suffer lifelong consequences, many studies have pointed out. So it's very important that we prevent the lung injury. Rather than going on treating it, we should prevent it at the outset. First golden hour is the most important time when we can do that. And there is some Indian data, found a study which is published from PGA in 2002 by Rajesh et al. And they found that the incidence of CLU is almost similar to what Western people have reported. In babies who were less than 28 weeks and less than 1 kg, almost if the baby was not ventilated, around 30% of babies or up to 50% had later on developed CLD. And if they are ventilated, almost 66% of babies later on develop BPD. So it's not that in India we are not getting, and this is an old study. Even now I think incidence, because more and more preemies are being saved, so incidence is even higher. Some of them are maybe mild CLDs which may be missing, but we have a considerable number of babies who have this problem.
There is a study from North India in the babies less than 33 weeks, it shows about 11.6%, and from our unit, the babies less than 29 weeks, we have incidence of about 17%. And all of us are worried about BPD because it is associated with poor neurodevelopmental outcome. So can you tell us that how can we predict BPD in our units, and what are the critical contributing factors?
Again, prediction is very important, because if you want to do some prevention of the injury, we have to predict those babies who are going to develop this BPD. Because once things have set in, then it's very difficult to do that. And there have been many clinical models, clinical risk factor based models, and a recent meta-analysis has been published on these, in which 26 clinical prediction models from all of the world were included, and 19 were found to be externally validated. But out of these, only 2 were found to be actually having some scientific basis. And one of these models was NICHD BPD model, published in 2012. And they found that the most important criteria for this prediction of BPD was gestation age, birth weight, race, sex, respiratory support, a type of respiratory, invasive, non-invasive, high frequency, and FIB required by the baby. But obviously in our units we can see many other factors. If the baby is needing frequent blood transfusion, the baby is having frequent antibiotics, and air leaks are there, obviously that baby is probably going towards CLD. And along with clinical predictors, there are some recent studies, they have found biomarkers and some respiratory mechanics based studies, and omics, means like there's always a genetic predisposition to all diseases. So genomics, epigenomics, microbiomics and metabolomics are also being increasingly used in various trials for early prediction of BPD, but as of now they are not coming to the clinical domain. There's a recent Chinese study on nasal microbiome in which they found some bacteria were more prominent in those babies who later on developed CLD. So it's very important to predict it, but as of now we don't have any single clinical model which you can tell to the audience that we can use this to predict BPD.
Okay. Actually, in our unit, we have used NICHD BPD predictor, and what we found that the prediction was significantly good when it was done on day 1 and day 3, and the area under the curve was almost about 0.7, 0.9. So it showed a good prediction. It's under publication right now. The next question to you is that what are our current protective strategies?
So first we should know what is the cause of this lung injury. Volume trauma, excessive tidal volume, I think the single biggest reason for the lung injury. Then atelectrotrauma, which is frequently ignored, but now increasingly we are getting the
I think you go ahead because,
Yeah. So atelectrotrauma, inadequate recruitment, but with the advent of now open lung strategies, increasingly people are realizing that atelectrotrauma is equally important as volume trauma. Regional overdistension and repetitive overstretching, these are the things, if we try to avoid these, then obviously we'll be protecting the lungs. It starts from delivery room itself with the nasal CPAP. Avoidance of endotracheal intubation as much as possible. And if we need to do it, if we need to give surfactant, then Ensure and Lisa techniques are better. We'll be coming later on the thing. Then can you have a previous slide, please?
sorry,
The
previous.
next one. No. Yeah. So the patient-triggered and synchronized ventilation is very important. Now, many trials have been published which show that this really helps in that. Volume guarantee and volume-targeted ventilation are increasingly coming up in even Indian units. Then HFO with open lung strategy and even conventional ventilation with optimal recruitment of lung and with using FiO2 as the criteria for optimal recruitment. And then permissive hypercapnia, these are all lung protection strategies which have been going on for many years and they have found to be beneficial. Next slide, please.
Okay, I think we'll skip this slide because we'll take more questions. So the next question is, what is the impact of non-invasive ventilation and which one do you prefer?
There are many non-invasive strategies, nasal CPAP, nasal IPPV, non-invasive neurally adjusted ventilator assist, nasal high-frequency ventilation and HHFNC, low flow of oxygen therapy. All these are non-invasive, but I found that, and the studies also found that NIPPV is the strategy which has shown to be the maximum beneficial as compared even to the nasal CPAP. And this systematic review by Ramaswamy et al. Has also showed that there is lower BPD rate and death rate for NIPPV when compared to nasal CPAP, and it's even better than nasal CPAP for prevention of BPD.
We have 3 panelists and at least we have given 8 minutes per organ. I don't know, I cannot cut short less than this. I think, what is the role of surfactant in preventing BPD? I think they want us to stop right now. So, role of surfactant in preventing BPD?
The surfactant has definitely a big role in preventing CPD since it has come into the picture. It has really changed the practice of neonatology. Now, which type of surfactant is more effective? So there is a Cochrane review on comparison of animal-derived surfactant for prevention and treatment of respiratory distress syndrome in this preterm infants, and they found that the porcine coractant alpha has been found to be better as compared to the miractant group, and better results are there, lesser chance of BPD and mortality is there, but the higher dose strategy, that's 200 mg per kg. Other surfactants, there is no difference in clinical outcome in other surfactants.
Okay, anything about surfactant techniques?
Many techniques are there. Most commonly researched are Ensure and Lisa. And when these two have been compared, it's found that Lisa with a thin catheter has shown a decrease in deaths in BPD and need for IV within 72 hours after Lisa. But point of caution is that a very large, recently concluded Optimist state trial has not shown any difference between these two strategies.
Okay. So what is your message for the use of postnatal steroids?
There have been many publications on postnatal steroids and CLD, and this is a summary of Cochrane reviews, a very busy slide. If you see only inhaled within less than 14 days, they have been found to decrease the incidence of BPD, but surprisingly there was quite significant increase in mortality in these babies. More than 7 days, there was no difference was there. Systematic only dexamethasone was found to decrease CLD, but along with that, it was found to increase the chances of cerebral palsy if we use it less than 7 days. If we use hydrocortisone, again it decreases the mortality and BPD by 36 weeks. If more than 7 days dexamethasone is used, then BPD is decreased, plus there is lesser chance, there is no increasing chance of cerebral palsy. So ideal strategy is after 7 days use of dexamethasone. Then this Previlog study is based on hydrocortisone therapy for extreme premature babies, and this is also found to be helpful within used in first 10 days, within first 10 days of life, it has been found to be useful.
Okay.
And last is the intratracheal corticosteroid administration, which Dr. Anup also had pointed out. Budesonide installation along with surfactant and compared with surfactant only group, again it has found to have lower risk of BPD as compared to the surfactant only group. But there is still a new therapy and it still needs a larger trial for.
Okay, so you just tell us in one line about future intervention.
Umbilical cord stem cell therapy and nutrients and microbiota angle in the lung disease of prematurity. The placental.
So these are the therapies on the horizon, and I think by the next few years we should be having answer for that. With this, we'll go to the second thing. That is, we are going to talk about neonatal protection on gut, and we have Dr. Jagjeet with us to talk about this. So, yeah. So we are going to talk about neonatal protection. Most of us are aware about protection of lung, protection of brain, but there is, this is something upcoming thing, newly coming thing. So let's learn from Dr. Jagjeet that why enlighten us about gut protection and tell us something. Is the gastrointestinal tract has any functions more than just the organ of digestion and absorption?
Thank you, ma'am. So, as we know that premature infants has underdeveloped GI system, and they are more susceptible for sepsis and feeding related issues. So, what is the gut protection? Is the providing the optimal gut function of a premature neonate and preventing NEC, sepsis, and feed intolerance by preventing the gut microbiota. So, prevention of damage to the gut microbiota is the thing that is upcoming to prevent the gut, to protect the gut.
Yeah. So, and again, the development of the nervous system and the development of intestinal microbiota is almost occurring at the same time, and there is a correlation between that, and that's why it is getting more and more importance. Can you tell us what do you mean by microbiota and what do you mean by microbiome?
Microbiota is